Hi all, and welcome to the day 4 of AETLS 2021. Today's theme is cardiac emergencies, and we have 4 lectures today and taken by 4 real experts in their own fields. The first session is titled as Evolution of Heart Failure Therapy, How Much Time Do I Have? This is covered by Dr. Rajesh sir. He is a professor and HOD of the Department of Adult Cardiology at Amrita Institute of Medical Sciences. So let's start with that session.
Good afternoon, everyone. It's a great honor to be presenting in AETLS 2021. And my topic is Evolution of Heart Failure Therapies. Over the next 25 minutes, I'm going to talk about the definition of heart failure, the newer diagnostic aids used in diagnosis of heart failure, the new landmark trials in heart failure with reduced ejection fraction. I'm going to dwell a little bit on heart failure with preserved ejection fraction, and I want to conclude by discussing about other therapies for heart failure. Over the last decade or so, there have been a plethora of pharmacological medications and newer therapies in the treatment of heart failure. And as of now, we're going to discuss all these in detail. Now, before that, I want to dwell on the diagnosis and the definition of heart failure. Basically, it's an abnormality of cardiac structure or function, which leads to failure of the heart to adequately perfuse organ systems. On this screen, you're on the right, you have a patient who has had a myocardial infarction and a large left ventricle because of LV dysfunction. And this LV function is not adequate to perfuse the different organ systems. This is heart failure. There are multiple causes of heart failure, and generally we can divide as valvular heart disease, pericardial disease, which like constrictive pericarditis, which can cause right side heart failure, high output states like anemia, sepsis, thyrotoxicosis, AV fistula, which can cause high output heart failure, volume overload, renal failure, and iatrogenic and postoperative fluid infusion, which can cause volume overload and right side heart failure. Different congenital heart diseases can also have present as heart failure. Arrhythmias, tachyarrhythmias can cause what is called tachycardia cardiomyopathies, and there are other disease conditions which involve the myocardium and endocardium, which can present as heart failure. If you look at the patient who presents with heart failure to the outpatient department, after the initial diagnosis and the treatment, the patient, some of them would end up getting admitted with acute decompensated heart failure. There are other group of patients who present to the ER with acute pulmonary edema, and then they get stabilized and subsequently get discharged home. This is the flow chart of a patient who presents with heart failure. If you look at the heart failure burden in our country, the current estimates is that about 1.3 to 23 million patients with heart failure are present at any point of time in our country. And the problem with heart failure is the patients can tend to get readmitted multiple times with breathing difficulty or heart failure symptoms. And all of us know that if you get readmitted with heart failure, the prognosis and outcomes are not good. 1/3 of heart failure patients also die within 1 year during their productive life years. So this is a huge problem, I think much worse than the cancer scenario in our country, and this goes largely unrecognized. If you look at the European Society of Heart Failure definition of heart failure, they are divided into 3 groups. One is heart failure with reduced ejection fraction. If you do an echo, there will be ejection fraction less than 40%. The second group is heart failure with preserved ejection fraction, LV ejection fraction of more than 50%, and they have classical heart failure symptoms. There's a new group of patients who have ejection fraction between 40 and 49%. We call it the heart failure with mid-range ejection fraction, and these patients are also classified in the European Society of Cardiology heart failure definition. So in addition to having symptoms and signs of heart failure, the patients need to have an echo documentation of LV function and an elevated biomarkers. The most common biomarker we use these days is N-terminal proBNP, along with echo features of diastolic dysfunction in patients with heart failure with preserved ejection fraction. Now, over the last decade or so, we are seeing multiple biomarkers. Biomarkers, essentially proteins which are elevated in heart failure, and they because the reason the biomarkers are elevated is because multiple disease processes which happen in heart failure. For example, there's myocardial injury, and that can cause elevation of troponin. There's renal dysfunction secondary to heart failure that can cause elevation of creatinine and cystatin C. And there is fibrosis in the myocardium, which can cause elevation of ST2 protein, galectin-2, and matrix metalloproteinases. There's also inflammation happening in the heart failure in patients in the myocardium, in patients' heart failure that can cause elevation of CRP, interleukin-6, and TNF-alpha. And then there's a chamber dilatation which happens in heart failure with reduced ejection fraction, which can cause elevation of natriuretic peptides like NT-proBNP. So because of the multiple processes which are happening in heart failure, the proteins are elevated, and these can be used as diagnostic markers in patients with heart failure. The most common biomarkers which are commonly used is NT-proBNP and the protein called ST2. So these biomarkers elevate heart failure, and they are useful aid in diagnosis of heart failure in patients who present to the emergency room with acute breathing difficulty. If you look at NT-proBNP, which has been used very widely, and patients who have very highly elevated NT-proBNP levels and whose levels do not come down with treatment, they are the worst prognosis compared to patients who have a low NT-proBNP levels at presentation and whose NT-proBNP levels come down with treatment. This can also prognosticate patients who have elevated NT-proBNP. So all the European Society of Cardiology and the American College of Cardiology has universally given a class 1 recommendation for use of NT-proBNP in the diagnosis of heart failure. And if you look at how has this pharmacological therapies evolved over the last 30 years or so in heart failure, we are fortunate to have multiple medications which can reduce the suffering and improve the outcome of patients with heart failure. Basically, how is this pharmacological therapy has come in? So all of us know when there's heart failure, there is there's activation of the sympathetic nervous system. Also, there's activation of the renin-angiotensin aldosterone system. So these two systems which are activated are deleterious for patients with heart failure. On the other hand, excuse me, there's another group of hormones which are activated. There's a natriuretic peptide system, and these are useful for patients with heart failure. So we need to have a healthy balance of this natriuretic peptide system, which should be in abundance, and the sympathetic nervous system and the RAS, which should be deactivated. So these are activated, as you know, sympathetic nervous system is activated. There's increased heart rate, increased contractility, and there's also vasoconstriction, which is deleterious for patients with heart failure. On the other hand, if you have increased natriuretic peptide system, so there's reduced blood pressure and there's reduced hypertrophy and fibrosis. So all the pharmacotherapy which has been designed in heart failure are useful in combating these two adverse systems which are activated. For example, beta blockers are effective in blocking the sympathetic nervous system, and the ACE inhibitors and ARBs are useful in blocking the renin-angiotensin aldosterone system. So we need so there's another group of enzymes which are present in the body. That's called neprilysin as an enzyme which tends to deactivate the natriuretic peptide system. It tends to break down the BNPs and the NT-proBNPs. So this we need to have another medication which is going to block neprilysin. I'm going to dwell that in the later part of my talk. So over the last 30 years, right from the beta blockers which came out as early as 1995, we have ACE inhibitors, ARBs, which are essentially useful in patients with heart failure. If you look at the trials, you look at beta blockers, there are Cibis, Capricorn, Copernicus, all looked at the usefulness of beta blockade in patients with heart failure. And there's a relative risk reduction. The mortality benefit of as high as 20 to 35% if you have a beta blocker in a patient with heart failure. Similarly, ACE inhibitors, all the earlier trials of Consensus, SOLVE, and the VALF trials, all have universally shown that ACE inhibitors are definitely useful in patients with heart failure. Similarly, the ARB trials, ELITE, 2, and the CHARM, and the VALF also shown the ARB is also potentially useful in improving the longevity of patients with heart failure. So that's apart from the benefit of all this medication, like ACE inhibitors, 16% mortality reduction, beta blockers, 34% mortality reduction, MRA antagonists, 30% mortality reduction, ARBs, 17% mortality reduction, and ivabradine, a 19% mortality reduction. There's a large unmet need for further reduction in mortality, and this is what the new medication is all about. Now, I'm going to talk in detail about this important molecule, which is called sacubital valsartan combination, or is also called LCZ696. This is a very important molecule which has made a paradigm shift in the way heart failure is treated these days. So this is a very important part of every prescription of a patient with heart failure. So what is the sacubital valsartan? Sacubital is a molecule which blocks neprilysin. As I mentioned before, neprilysin is a hormone which deactivates or degrades the natriuretic peptide system, which is beneficial in patient heart failure. So by blocking neprilysin, we are preventing the degradation of this useful peptides. And along with that, we have an angiotensin receptor blocker, which is valsartan. So this combination of sacubital valsartan, which is also nicknamed as LCZ696, is very useful in heart failure. This is the most important study, which is called the paradigm heart failure study. It was published as early as 10 years before, which has shown this is a multi-center randomized double-blind parallel group active control study, which compared this molecule with the standard of care therapy those days, which is enalapril in patients' heart failure. So after a rundown period of maybe 2 to 4 weeks, patients, around 8,000 patients were randomized into two groups, one on the LCZ arm, 200 milligram twice daily dosage, other patient and enalapril arm, 10 milligram twice daily dosage. They were followed up for nearly 2.5 years. And what did they find? They found a huge benefit as far as the mortality was concerned. The death death, and the primary endpoints was death from cardiovascular causes or first hospitalization for worsening of heart failure. The mortality benefit compared to enalapril was huge, a p-value of 0.001. And death alone from cardiovascular causes and hospitalization for worsening heart failure also significantly reduced in the LCZ696 arm. So the secondary outcomes were death from any cause, and the change in the Kansas City Cardiomyopathy Questionnaire, which is a questionnaire which is used in patient heart failure, and the new onset atrial fibrillation and declined renal function, all were significantly better in the LCZ, the 696 arm, compared to the enalapril, which is standard of care so these days. So if you look at the figures, 20% reduction in death from cardiovascular causes or heart failure hospitalization, death alone from cardiovascular causes, 20% reduction compared to enalapril, and first hospitalization for heart failure, 21% reduction compared to enalapril. So if you have this molecule on board in a patient heart failure, there's a 20% reduction in the composite outcomes of cardiovascular death, heart failure hospitalization, and all-cause mortality of 16%. This is, mind you, this is on compared to standard of care therapy, a patient already on beta blockers, ACE inhibitors, MRA, and the standard of care therapy for heart failure. So this has been a significant change or significant advance in the treatment of heart failure. This new molecule is readily available, and we have been using it for nearly 4.5 years since the time it was introduced in the Indian market. So this ARNI has an expanded role focusing on optimizing therapy for patients with heart failure. Not only the superior benefit compared to standard of care, it also causes a reverse cardiac remodeling effect, which is beneficial in patients with heart failure. So there's a huge Indian subset of patients with paradigm heart failure. Again, they showed the benefit of sacubital valsartan in patients with heart failure. So all the guidelines, if we look at the latest ACC 2021 American College of Cardiology guidelines for heart failure, this is the preferred over ACE inhibitors or ARBs for patients with heart failure with reduced ejection fraction. Again, you need to titrate the dose. Some patients have very low blood pressure presentation. They start a very low dose of 50 milligrams twice daily and gradually escalate the dose, reaching a dose of 200 milligrams twice daily. It's very important that when patients are on these medications, it's important that patients need not be dehydrated very well. You not be over dehydrated in the sense the patients on a last infusion or something, patient is dehydrated. Starting this medication can cause an elevation in renal parameters, which need to be carefully monitored. So this is the treatment algorithm for a patient with heart failure reduced ejection fraction. Upfront start ARNI before when the patient presents to the ER or patient presents to the CCU. Again, the other trial, which is again compared enalapril and sacubital valsartan, this looked at NT-proBNP reductions called the Pioneer Heart Failure trial. Again, showed a benefit of sacubital valsartan compared to enalapril. Again, as far as worsening renal parameters are concerned, hyperkalemia, which is a concern when you're starting ACE inhibitors, again, this is superiority of this molecule over other medications. So this, again, it's very important that any patient in this current scenario should be on Circulatory Valsartan combination in patient present with heart failure with reduced ejection fraction. Now we have shift away from heart failure reduced ejection fraction to another group of conditions which are gaining in importance these days. This is heart failure with preserved ejection fraction. As I mentioned before, heart failure preserved ejection fraction means you need to have an echo documentation of ejection fraction more than 50%, and patient needs to have classical symptoms of heart failure like pedal edema, raised JFP, tendon hepatomegaly. Along with that, we need to have documentation of diastolic dysfunction like LV hypertrophy, Doppler evidences of diastolic dysfunction like raised E by E prime ratio, elevated biomarkers, and other invasive hemodynamic modulations. So if you how to differentiate between heart failure reduced ejection fraction and heart failure with preserved ejection fraction, the most important thing is do an echo. Ejection fraction is less than 40%, reduced ejection fraction above 50% is preserved ejection fraction. Now, heart failure preserved ejection fraction is seen most commonly in females. Most of them are older females, the short stature, history of hypertension, atrial fibrillation in the past, and we do an echo. We find this LVH and left atrial dilatation, and they also will have myocardial inflammation, fibrosis, and they'll have a normal LV systolic function. There are different echo indices to diagnose diastolic dysfunction. I won't go into details of this, but just to mention that you look at annular longitudinal myocardial shortening and peak velocity shortening, etc. when you have diagnosed echo and diastolic dysfunction. Again, we also use CMR for diagnosis. We find extensive myocardial fibrosis in patients with heart failure preserved ejection fraction. Now, what is the scenario in our country? Approximately 30% of patients with present heart failure have heart failure with preserved ejection fraction. Females contribute to majority of this group, and most of them will have history of atrial fibrillation and hypertension in the past. So all these guidelines have stressed the need to diagnose patients' heart failure. And there's a heart failure PFF score, which looks at initial workup. If you look at the last 5 alphabets, PEFF, P stands for pre-test assessment, E stands for echocardiography, F stands for advanced workup, and F2 stands for etiological workup. And there's a score which has come. If you have a more than 5-point score, it's based on 2 major criteria, 1 minor criteria. It is diagnosis or it's confirmatory diagnosis of heart failure preserved ejection fraction. So when you shift from heart failure preserved ejection fraction to other new molecule, other new kid on the block, which is called SGLT2 inhibitors, which are very, very useful in patient heart failure. As you know, SGLT2 inhibitors, they inhibit the absorption of glucose and sodium in the proximal columnar tubule. By that, they cause excretion of glucose and excretion of sodium, and they have a diuretic effect also. So this medications came as for initially for diabetes treatment, but now this is expanded to non-diabetic patients also. So this is based on this trial. This is called the DAPA-HF trial, which looked at dapagliflozin, which is the SGLT2 inhibitor in patients with heart failure with a reduced ejection fraction. They found there's a 26% relative risk reduction in the cardiovascular death and hospitalization for heart failure in patients who are on this molecule compared to standard of care therapy, which included an ARNI and patient ACE inhibitors also. So there's consistent benefit. It has shown that SGLT2 inhibitors not only reduce the mortality of patients' heart failure, they also reduce the risk of recurrent hospitalizations, also significantly reduce the risk of cardiovascular death and hospitalization for heart failure. This is an important armamentarium in the diagnosis of heart failure in the treatment of patients' heart failure, because it has significantly reduced heart failure death as well as hospitalization for heart failure in patients with heart failure reduced ejection fraction. So, so we have a very important molecule which I mentioned before, Circulatory Valsartan, and this SGLT2 inhibitors, namely empagliflozin and dapagliflozin, which is an essential part of every prescription of a patient with heart failure with reduced ejection fraction. So moving away from pharmacotherapy, we also discuss in a minute or so what are other treatment available for heart failure with reduced ejection fraction. Commonly we use a device called cardiac resynchronization therapy, or a defibrillator, which improves the contractility of patients' heart failure. Also, we use a defibrillator to reduce the mortality of patients with heart failure. Then there are other surgical options available, like mitral valve repair in patients who have mitral regurgitation, and heart transplantation in patients who have decompensated heart failure. So I want to thank each one of you for this opportunity to listen to my talk. I also want to thank the organizers, Dr. Sabarish, Dr. Girish, and Dr. Srikrishnan, who gave me this opportunity to be presenting before you. Thank you very much.
Thank you, Rajesh sir. That was a very, very informative session. We'll move on to the second session for the day. That is pulmonary edema. What can the X-rays say? So X-rays are often a kind of an overlooked investigation in pulmonary edema. So this session will be taken by our beloved Dr. Girish Kumar sir, Professor and HOD of the Department of Emergency Medicine. Over to sir.
Good afternoon to all viewers of AETLS. Now we are discussing about one of the important tools in the emergency room, that is chest X-ray. Chest X-ray in cardiac failure. We will see what are the features we can make out from X-ray in cardiac failure. We'll also discuss some of the treatment aspects of cardiac failure. Let us discuss about X-ray features of acute cardiac failure, that is patient presenting with acute pulmonary edema. We'll see the X-ray findings. The normal X-ray findings in patients who is having acute pulmonary edema are curly B lines or thickening of the interlobular septa. They are short parallel lines located at the lung periphery. Cephalization of blood vessels. So upper lobe blood vessels will be very prominent. Increased cardiothoracic ratio. The cardiac ratio will be more than 50% of the thoracic ratio. The whole thoracic ratio we have to take, cardiac measurement you have to take. If cardiac measurement or length of the cardiac shadow is more than 50% of the thoracic length, then it is cardiomegaly. Peri-Bronchial coughing, that the area around the bronchus to appear more prominent on chest X-ray. That is another finding. Thickening of fissures due to fluid can fill into that fissures and can make it prominent. Increased vascular markings. This can be seen in early lung infections or ARDS. All conditions you can get same finding. It's not specific for pulmonary edema. Interstitial edema can be there. Batwing opacities, bilateral perihilar shadowing. All these are the common findings you see in patients who is having pulmonary edema. Pulmonary edema means because of cardiac failure, left ventricular failure, fluid accumulates in lungs and patient will be acutely breathless. So patient will be unable to sit. Hypoxemia will be there. So when we take an X-ray, it may not be possible to take an X-ray in all cardiac failure. If you take an X-ray, one of the most prominent finding what you can see in X-ray will be curly B lines. Here you can see in this X-ray, patient is having cardiomegaly, bilaterally extensive small lesions you can see. It's not lesions, white patches you can see. That is due to fluids. Again you can see some lines, they are called as curly A, curly B and curly C lines. We are discussing about curly B lines. They are small horizontal peripheral straight lines. Seen at the lung bases, it represents thickened interlobular septa. So it is due to edema of interlobular septa and it is not very specific. You can get in various other conditions like ARDS also you can get. But this is seen in pulmonary edema. So curly A lines and curly C lines also seen in pulmonary edema. Curly B lines is a prominent line which is seen in patients who is having increased fluid in the lungs. Now cephalization of blood vessels. That means redistribution of blood into upper lobe vessels. It refers to redistribution of blood into the upper lobe vessels. It has been hypothesized that once the hydrostatic pressure exceeds 10 mm of mercury, then the fluid begins to leak into the interstitium of the lung. So you can see in this X-ray, upper part of the lung, there are a lot of white markings. They are blood vessels. So this is called as cephalization of blood vessels. You can see patient is having cardiac enlargement and upper lobe blood vessels are very prominent. This is cephalization. This is one of the features seen in pulmonary edema, early pulmonary edema. Now all patients who is having pulmonary edema, they will have a cardiomegaly. You can see here transthoracic diameter, that is in blue line. The reading can be taken in that blue line, and cardiac diameter can be taken in that orange line. So if it is more than 50% of the transthoracic diameter, then it indicates cardiomegaly. So if the patient is having cardiomegaly, then if the patient come with acute breathlessness, then it is due to cardiac failure induced pulmonary edema. There are some conditions where the patient can have non-cardiogenic pulmonary edema, like ARDS is a non-cardiogenic pulmonary edema. There you may not see this enlarged heart. So increased cardiothoracic ratio more than 0.5, that is more than 50% of the total thoracic diameter is cardiac diameter, then you can call it as cardiomegaly. Now next finding will be peri-bronchial coughing. Here the area around the bronchus, you can see the black dots are bronchus. Surrounding that you can see white prominent markings. So black is air, that is bronchus. White is blood. So peri-bronchial coughing due to fluid or blood. That is also a finding seen in patients who is having pulmonary edema, peri-bronchial coughing. Now thickening of interlobar fissures is another important feature you can see in pulmonary edema. You can see in the first X-ray there is minimal infiltration of interlobar fissure. The next X-ray you can see a large tumor like swelling. If you give Lasix or furosemide, this will disappear. That's why it's sometimes called as phantom tumor or vanishing lung syndrome. So when the patient presents with acute breathlessness, when we take an X-ray, you can see a tumor like swelling in the right side of the lung. After giving Lasix, it may disappear. That's why it is called as phantom tumor or vanishing lung syndrome. Now increased vascular markings can be seen in many conditions including pulmonary edema. You can see white thread-like structures radiating from the heart. They are blood vessels. It can be seen in acute like lung infections, early pulmonary edema, early ARDS. So many conditions you can get similar finding. So it is not a typical feature of any disease, but this is seen in early pulmonary edema. Batwing appearance is another important finding. You can see here it's like a batwing. There will be perihilar shadowing. White shadows are seen surrounding the hilum of the X-ray. You can see in the X-ray in the perihilar area you can see a lot of white infiltrates. They are fluid. So this is a classical finding of pulmonary edema. This is called as batwing opacities or batwing appearance in the chest X-ray. Now we'll see how to manage a case of pulmonary edema or acute cardiac failure in emergency room. Take the patient inside emergency room, put the patient in propped up position, take care is airway, breathing, circulation. So if the patient is having desaturation, start with oxygen. Initially you can give nasal prongs, then face mask, then NIV. If the patient is not improving, NIV is the best treatment for pulmonary edema because it can displace the fluid from the alveoli and increases the aeration in the alveoli. So NIV should be started for all patients who is having acute pulmonary edema. Diuretics like Lasix is one of the important treatment options in pulmonary edema, but it is useful when there is no renal failure. If there is renal failure and complete renal shutdown, Lasix will not work. So Lasix can be given in a patient who is having cardiac failure or pulmonary edema. If there is good urine output, Lasix will definitely work. So you can give 40 to 80 milligram IV bolus if the BP is good. If the BP is low, if the patient is having hypotension, start Lasix as infusion. So if the patient is having hypotension, we can start noradrenaline, then add dobutamine. To improve the cardiac pumping, dobutamine will help, but to maintain the BP, noradrenaline may be needed initially. Now, NTG can be done in a patient who is having ischemic heart disease, cardiomegaly, and high BP with pulmonary edema. NTG can be used. So if the patient is having very high BP and is not able to getting control with other drugs, nitroprusside can be started. Nitroprusside infusion can be started. Once the patient is stabilized, we have to start the patient on diuretics, angiotensin system inhibitors like AC inhibitor or ARB. Then to control the heart rate, we have to start beta blocker. Second line drugs are mineralocorticoid receptor antagonist, ivabaradine, hydralazine, nitrates, all are second line drugs. So mainly in emergency room, we have to start Lasix, spironolactone. Then to improve the cardiac function, we have to start him on dobutamine with noradrenaline. Then drugs like AC inhibitor, ARBs should be started for preventing ventricular remodeling. Then beta blockers can be added to control the heart rate and improve the cardiac function. So these are the treatment options in cardiac failure. Now we have seen what are the changes we can diagnose from chest X-ray in cardiac failure, and some of the management protocols also I just discussed. Thank you.
Thank you, Girish sir. We'll be moving on to the third session of the day. That's going to be taken by Dr. Hisham Ahmed, who is an associate professor in the Department of Adult Cardiology at Amrita Institute of Medical Sciences. And the session is titled as Case-Based Discussion, a Patient with Worsening Heart Failure. And I'm sure there will be a lot of teaching lessons for each of you. Let's move on to the session.
Good morning, everyone. At the outset, let me congratulate the organizing team behind this year's AELTS meeting for setting up a fantastic conference, and as always, it's a privilege to be here. Over the next 20 minutes or so, we'll be considering a short case-based discussion of a patient with heart failure. Over the next couple of slides, we will be looking at the mode of clinical presentation, the symptomatology of this patient, the progression of this patient's clinical disease, and we'll also be looking at the various ways with which we can optimally manage such a patient in today's contemporary era of heart failure management. Let's dive right into our case, and our patient is a 55-year-old gentleman who's been diagnosed with heart failure since the last 4 years, and the type of heart failure which he has is heart failure with reduced ejection fraction. If you're looking at his medical history for heart failure, he's currently on a dose of ACE inhibitor, beta blocker, diuretic, and mineralocorticoid receptor antagonist in the form of spironolactone. He was doing reasonably well on medication, but of late, recently, he has been complaining of difficulty in breathing, slight swelling of his feet, and increased fatigue. What he says is he usually lives on the first floor, and he usually takes the stairs to reach the first floor, but of late, he prefers to take an elevator due to the progression of his symptoms, in the sense he has experienced a worsening of breathlessness on exertion. Whenever a patient presents with worsening heart failure symptoms, as this gentleman has, it always calls for a reassessment of the patient in terms of cardiac imaging and the relevant biochemistry, including cardiac biomarkers such as NT-proBNP. As you can see in this patient, the echo revealed a reduced ejection fraction of close to 26%, which indicates its severe left ventricular systolic dysfunction, an elevated NT-proBNP of 625. He has a BMI of 28, serum creatinine, which is in the normal range, stable hemodynamics with a blood pressure of 120/82, and a serum potassium level of 4 millimoles per liter. So with the background of this diagnosis, he has NYHA class 2, heart failure with reduced ejection fraction status with recent worsening of symptoms. So this patient that we're discussing clearly is in NYHA class 2 functional status, and generally patients with heart failure with NYHA class 2 are considered to be generally stable, and they're often perceived as low risk, which may be true to some extent because they are stable from the point of view of stable hemodynamics. But this perception is largely wrong because the pathological process of heart failure may be still progressing in the background in spite of this apparent stability. That's why when you have a patient with NYHA class 2 in heart failure, they are generally perceived as stable disease, they are perceived as low risk, and due to this, there is a huge inertia on the patient's and the physician's part to optimize care of these patients. And of course, there are concerns about multiple hospital visits and side effects of the various measures which may be taken to optimize such a patient's care. And of course, we might end up changing therapy only when the patient actually worsens, rather than intervening quite early on in the natural history of this disease. And so in such a patient with apparently stable heart failure with NYHA functional class 2, we have two options as clinicians as we move forward with the therapy of this patient. One option is to say, look, this patient is quite stable now or is apparently stable now, and let's continue the current line of pharmacological therapy for this patient, and let's intervene only when the patient really worsens clinically. The other option is to intervene at a quite early stage, intervene during this apparently stable clinical stage by optimizing the medications of this patient so as to favorably influence the natural history of this disease. And of course, I think with today's evidence, the clear answer would be option 2, that the patient will definitely need a treatment change quite early on. And the next couple of slides, I'll show you why this early intervention is needed. And the first step is to understand why the idea that our patient is now in a stable phase of his disease is actually a misconception. Heart failure with reduced ejection fraction is a relentlessly progressive disorder. So the cardiac structure and function, they continue to deteriorate. And they continue to deteriorate despite the absence of markedly apparent clinical signs and symptoms. The infographic in this slide clearly demonstrates the concept that heart failure with reduced ejection fraction patients can never be considered as low risk or clinically stable. If you look at the infographic here, starting from the baseline clinical status of patients with heart failure with reduced ejection fraction, every dip that you see on this infographic represents worsening heart failure or decompensated heart failure needing hospitalization. You can clearly see that with every dip in the natural history of this patient, this actually represents progressive deterioration in the heart failure status of this patient, and there is an overall downward trajectory in the clinical course of this patient. So with every dip, with every heart failure hospitalization, there is a reduction in the cardiac function and quality of life. There is progressive deterioration in terms of disease progression, and of course this is accompanied by a steady rise in mortality and morbidity. The risk of mortality definitely remains high in patients with worsening heart failure. As you can see on the left side of the panel, most of the clinically stable heart failure with reduced ejection fraction patients, they may have mild to moderate heart failure symptoms, and on physical examination, they may have mild or no symptoms, signs and symptoms suggestive of worsening heart failure. But at the same time, these patients might be having ongoing structural and functional deterioration as manifested by a chronic increase in plasma troponin. They may have cardiomyocyte loss as a result of continuing inflammation, oxidative stress, and myocardial cell wall stretch. And this entire process is often associated with neurohormonal activation. Now, when this process continues unabated, many of these patients may succumb to sudden cardiac death or death from pump failure. When you look at the data set from Paradigm HF trial, which was a landmark trial in heart failure, and in this particular case, the data set which was looked at was the cardiac adverse event rates in relation to the baseline NYHA functional class. And as you can see, the patients who required heart failure hospitalization, emergency department visits, or who required intensification of therapy and who succumbed to cardiovascular death, these patients were looked at from the point of view of their initial NYHA class. And as you can see, approximately 7 out of 10 NYHA class 2, the so-called stable patients with heart failure with reduced ejection fraction, they experienced clinical worsening, including readmission to the hospital for worsening heart failure and death from a cardiovascular cause. Another subgroup analysis from the same data set from the Paradigm HF study also looked at what happens to the NYHA class 2 patients, the so-called stable patients, in terms of mortality. And what was revealed was that approximately 6 out of 10 NYHA class 2 patients with heart failure with reduced ejection fraction, they had cardiovascular mortality at 27 months. And this is quite an alarming statistic. So from the previous series of slides, I think we can safely conclude this clinical lesson. And the clinical lesson is that mild symptoms in patients with heart failure with reduced ejection fraction should not be used as a reason to do or change nothing in these patients. And we must always remember that optimization of heart failure care in these patients is always a dynamic process. And naturally, this brings us to the question, what can be done to improve the outcomes in patients who are apparently stable with NYHA functional class 2, like our patient who has heart failure with reduced ejection fraction. In the next couple of slides, by summarizing key points of current evidence, I'd like to show you that we can actually do quite a lot. The first step in actually pursuing optimization of heart failure care in these patients is to actually uncover mild symptoms which are suggestive of the worsening heart failure status. These mild symptoms which may hide in plain sight. For example, subtle changes in patient symptoms or patient's behavior may include things such as patients may get tired very easily of late. They might be having difficulty in sleeping at night, or they might be holding back from their regular hobbies. They might have, they might have noticed trouble in breathing or difficulty in doing, usual activities like taking a stroll around the house. And of course, in our patient, there was this history where clearly he preferred to take the elevator instead of the stairs because of a worsening in functional class. And of course, the next step would be, after having recognized that there is a deterioration in the clinical status of a patient, would be to ensure that the patient is on all the foundational therapies for heart failure. The foundational therapies for heart failure are represented by beta blockers, which counter the inappropriate sympathetic nervous system activation. ACE inhibitors, ARBs, and MRAs will counter the inappropriate activation of the renin-angiotensin-aldosterone axis. A class of drugs known as neprilysin inhibitors will ensure that there are more of natriuretic peptides available in the circulation, which again is a key tool in the management of patients with heart failure. And of course, these foundational therapies can be helped by additional agents such as ivabradine, diuretics, digoxin, and the combination of hydralazine with nitrates. However, despite the widespread use of the foundational therapies of heart failure over the last 2 decades, clearly the mortality of heart failure patients has not markedly come down. In fact, 50% of patients, they die at the end of 5 years after diagnosis of heart failure. So the question is, how do we prevent the ongoing deterioration of patients with heart failure with reduced ejection fraction who are already on the established foundational therapies that we saw in the previous slide? Um, and clearly the answer lies in the fact that novel therapies are definitely needed to counteract the ongoing deterioration of heart failure with reduced ejection fraction. And I'm going to show you one such novel therapy which has made a big difference in the management of these patients. And one of the novel therapies which has made a big change in the way we manage patients in our heart failure is the drug called sacubitril valsartan. Sacubitril valsartan is a combination of a neprilysin inhibitor, which is sacubitril, and valsartan, which is an angiotensin II type 1 receptor blocker. And this is now strongly recommended as a first-line agent in all of the recent guidelines for the therapy of patients with heart failure with reduced ejection fraction, thereby highlighting the recommendation for a direct to ARNI approach. So ARNI is the drug class to which sacubitril valsartan belongs to. And therefore, clearly, ARNI is now the preferred inhibitor of the renin-angiotensin-aldosterone axis for heart failure with reduced ejection fraction patients over ACE inhibitors or ARBs, and this is accompanied by robust data. Now, while managing a patient with heart failure with reduced ejection fraction who has an NYHA functional class 2, which of these two therapeutic strategies would we pursue? Therapy A is a strategy in which we stick with standard therapy and we go with either an ACE inhibitor or an ARB. Therapy B is a strategy where we use sacubitril valsartan upfront as a first-line therapy. Now, before we choose one of these strategies, we must first understand what exactly does sacubitril valsartan do. As I mentioned before, the drug class ARNI is a combination of sacubitril and valsartan. Sacubitril is a neprilysin inhibitor, which makes sure that a larger proportion of natriuretic peptides are available in the circulation, which in turn leads to favorable effects on the vasculature and at the tissue level. At the same time, valsartan, which is an angiotensin II type 1 receptor blocker, manages to counteract these adverse effects of vasoconstriction and hence, again, playing a key role in the management of heart failure with reduced ejection fraction. So you can see that sacubitril valsartan not only blocks the renin-angiotensin system, but it also clearly enhances the activity of vasoactive substances such as natriuretic peptides, thus paving the way for a paradigm shift in the management of patients with heart failure. So the question one may ask is, how does the combination of sacubitril valsartan potentially score over using either an ACE inhibitor or an ARB alone? So as you can see, by inhibition of neprilysin, there are more natriuretic peptides which are available, which causes vasorelaxation, natriuresis, and diuresis, which in turn potentiates the inhibition of cardiac fibrosis and cardiomyocyte hypertrophy. On the other side of things, it simultaneously blocks the angiotensin II type 1 receptor by virtue of valsartan, and it clearly suppresses vasoconstriction and reduces sodium and water retention, and this definitely ameliorates the congestive heart failure state. So inhibition of neprilysin and simultaneous blockage of the AT1 receptor clearly acts on the underlying structural and molecular abnormalities, which clearly drives forward the pathological process of heart failure. As I mentioned earlier, the evidence which supports the use of sacubitril valsartan in clinical practice is quite robust, and in the Paradigm HF trial, when sacubitril valsartan was compared with enalapril in patients with heart failure with reduced ejection fraction, you can see that it was accompanied by a 20% reduction in the composite of death from cardiovascular causes or hospitalization of heart failure, a 20% reduction in death from cardiovascular causes, and a 21% relative risk reduction from the first hospitalization for heart failure. And all this is in comparison to enalapril. Another interesting point about the heart failure population, which was studied in the Paradigm HF landmark trial, was that the majority of the patients belonged to NYHA class 2, like the patient that we were discussing. So approximately 72% of patients with heart failure with reduced ejection fraction in the Paradigm HF trial belong to NYHA class 2. And that's an important statistic to keep in mind because according to the data from the Paradigm HF trial, the patients who were in NYHA class 2 derived the maximum cardioprotective effects from the combination of sacubitril valsartan as compared to the other NYHA functional class patients. This is another way of saying that these drugs, when used quite early in the natural history of heart failure, those are the patients who are likely to benefit from the cardioprotective effects of this particular drug combination. Even if you look at the outcomes from the point of view of cardiovascular death, again, it was the patients in NYHA class 2 functional class which derived the maximum protection from cardiovascular death, maximum reduction in cardiovascular death as compared to the other NYHA functional class patients. And looking at the outcomes from the point of view of the mode of death, the modes of death could be either due to sudden cardiac death or due to progressive heart failure and pump failure, leading on to cardiovascular death. So as you can see from the slide, sacubitril valsartan favorably impacted the number of patients who had succumbed to either of the two modes of death. And you can see there was a 16% relative risk reduction from all-cause mortality, a 20% relative risk reduction from a death due to cardiovascular causes, a 20% relative risk reduction when you look at sudden cardiac death, and another 21% relative risk reduction when you look at the number of patients who are dying from pump failure and worsening heart failure. Subgroup analysis from the Paradigm HF trial dataset in terms of two different age groups, that is survival after age 55 years and survival after age 65 years, also clearly show that the usage of these drugs in this trial population also significantly led to approximately 1 to 2 years of extended survival time when they were followed up during the duration of the trial period. Apart from the objective adverse cardiovascular events which were taken into account as primary and secondary outcomes, even if you look at the Paradigm heart failure data from the point of view of the quality of life, you can clearly see that there was a significant increase in the odds of the patients who were treated with sacubitril valsartan to achieve a 5-point or greater improvement in the change of the quality of life score difference at 8 months when they were being followed up. So clearly, not only is there an objective impact in terms of cardiovascular outcomes, there's also a clear impact on the quality of life in patients who are treated with sacubitril valsartan. So in summary, in a patient like ours who has heart failure with reduced ejection fraction and NYHA class 2, even the presence of mild symptoms or mild worsening clinically will lead to a markedly increased incidence in heart failure hospitalization and its accompanying increased risk of mortality. Therefore, the time to initiate novel therapies such as sacubitril valsartan is now in the early stage of this apparent stability of heart failure. And such a strategy will significantly lead to marked reduction in the clinical worsening of NYHA class 2 heart failure with reduced ejection fraction patients. And this will also lead to a substantial improvement in the quality of life. And as we saw in the previous two slides, it also affords a significant component of extending the survival time in heart failure with reduced ejection fraction patients. As we have seen in the previous slides, the usage of a novel agent such as sacubitril valsartan has created a major impact in terms of favorably influencing the natural history of a patient with heart failure with reduced ejection fraction. However, at this point, I'd like to emphasize that the usage of a novel agent such as Circulatory Valsartan is merely a cog in the wheel of the foundational therapy of heart failure. What I'd like to emphasize is that the best impact or the highest impact of using novel agents are achieved when they are used together with the other foundational therapies of heart failure, namely the beta blockers and the SGLT2 inhibitors. The SGLT2 inhibitors are a novel drug class which has been approved for heart failure with reduced as well as preserved ejection fraction. And of course, as you move down the rapid sequencing steps, one may also need to use mineralocorticoid receptor antagonists for the optimum management of patients with heart failure with reduced ejection fraction. And finally, this is a bird's eye view of the treatment algorithms involved in the treatment of patients with heart failure with reduced ejection fraction. And as you can see, as the first step, this involves the rapid sequencing of the foundational therapies of heart failure, as we saw in the previous couple of slides. An ICD should be offered for those patients with heart failure with reduced ejection fraction who are considered to be at high risk of sudden cardiac death, and if the patient fulfills the criteria for secondary or primary prevention of sudden cardiac death, they should receive an ICD. For those patients who have clinical features such as LV ejection fraction of less than 35% and a QRS duration of more than 130 milliseconds, features which might be considered appropriate to receive a CRT-D device for resynchronization therapy, those patients should proceed to cardiac resynchronization therapy as well. And for those patients whose symptoms persist despite the first steps of rapid sequence treatment involving the foundational therapies of heart failure, other therapies can be considered, which has class 2 recommendations involving the addition of digoxin or agents such as ivabradine. So this in effect summarizes the approach to the treatment of patients with heart failure with reduced ejection fraction. Thank you for your patient listening, and I'd be happy to take any questions.
Thank you, Dr. Hisham. And to the audience, please do share your questions in the comment box. The speakers will be answering it, or ourselves will be answering the questions in the comment itself. So we'll be moving on to the fourth and the last session for the day, that is titled as Acute Management of Iotic Dissection, and this session is being taken by Dr. Kiran Gopal, who is an associate professor in the Department of CVTS at Amrita Institute of Medical Sciences. Over to Dr. Kiran.
Welcome to AETLS 2021. I'm Dr. Kiran Gopal, cardiac surgeon at Amrita Hospital, Kochi. I'll be talking to you about type A aortic dissection. Hi, I'm going to talk to you about the diagnosis and management of type A aortic dissection. During this talk, I'll be covering the pathophysiology, the incidence, the presentation, investigations, treatment, long-term outcomes, and our current clinical practice. I'll start with the patient case. Mr. John was a 50-year-old male from Palakkad, which is an adjoining district from our center, who presented with a sudden onset of severe chest pain. He was evaluated at the local hospital there and was detected by echo to have a flap in the ascending aorta and was diagnosed with an aortic dissection and referred to us for further treatment. On admission to the ER, he had significant chest pain. He was hypertensive. He was neurologically intact and had no pulse deficits. In the ER, the bedside transthoracic echocardiogram demonstrated the flap in the ascending aorta, and he was started on an NTG infusion. The CVTS OT and IC were alerted, and a blood workup for surgery was sent. And then he was wheeled stat to the CT scan, where a type A aortic dissection was confirmed. He was shifted from there straight to the OT, and on opening the pericardium, his aorta ruptured. So, acute aortic dissection belongs to a spectrum of diseases which share a common life-threatening medical conditions with common pathophysiological pathways, clinical characteristics, and diagnostic and therapeutic challenges. These include aortic dissection, aortic intramural hematoma, and penetrating atherosclerotic ulcers, which all come under the spectrum of acute aortic syndromes. But among these, by far the most common is acute aortic dissection, which occurs in 75 to 95% of patients. Acute aortic dissection was first described in 1819, and basically it involves a creation of a false lumen within the walls of the aorta due to the presence of a tear in the intima. It's a relatively uncommon condition, with the incidence being only around 3 per 100,000 patient years. But the importance lies in its mortality. The in-hospital, non-surgical, medically treated patient mortality is in excess of 50%. Let's compare this to another condition which presents to the ER with chest pain, which is myocardial infarction. As we all know, South Asia, India, which is part of South Asia, is the third highest area in the world for incidence of myocardial infarction, and the incidence of coronary artery disease in the male population is around 245 per 100,000 population. So if we compare that, and if we look at the mortality of a myocardial infarction, we can see, like, this is a longitudinal study of a Danish population from 1984 to 2008, and we can see that the mortality there is only around 0.2 to 0.3%. So this is for all comers presenting with myocardial infarction. The mortality is only 0.2 to 0.3%. And if you remember what I mentioned in the earlier slide, though the incidence of aortic dissection is only 3 per 100,000, the mortality is in excess of 50%. So therein lies the importance of diagnosis and treatment of this disease. So coming to the pathophysiology, the inciting event for an aortic dissection is an intimal tear in the inner layer of the aorta, the intima, which results in blood entering into the media and creating a false lumen or false channel, which then extends along the aorta into the downstream aorta. So thus you have on cross section, you can see two lumens in the aorta, the true lumen and the false lumen. So if you do a cross section analysis of a dissected aorta, you'll see there will be two lumens, a true lumen and a false lumen, separated by an intimal flap. And that intimal flap is composed of the intima and part of the media, which is separated by the tear in the aorta. So you have basically a double lumen aorta separated by an intimal flap. And then what happens to the false lumen in the downstream aorta? So as this blood enters into the false lumen, it propagates down the aorta due to the blood pressure in the aorta. So, and it has to exit somewhere because it's under pressure. So it can either exit out, that is, it can rupture out of the aorta, which is obviously a life-threatening condition, or it can rupture back into the aorta or get decompressed through one of the side branches of the aorta, which come off the false lumen. So like I mentioned, the main problem with dissections is rupture. So we have to remember that the aorta is like a cylindrical vessel, so it follows Laplace's law. And as we know, Laplace's law, the tension in the wall of any structure is directly proportional to the distending pressure, directly proportional to the radius of the vessel, and inversely related to the thickness of the vessel wall. So if you remember, the normal aortic wall has an adventitia, a media, and an intima. So at the time of dissection, when the intima ruptures and the blood enters the false lumen, immediately you have a double lumen aorta. So there's an immediate increase in the size of the aorta from a normal 2 centimeter, immediately it becomes 2.5 to 3 or even 4 centimeters. So there's an increase in size when it becomes a double lumen vessel. And also you can see that if you look at the wall of the false lumen, where initially it was adventitia, media, and intima, in the false lumen, the wall is only composed of the adventitia and the part of the media. So it's become thinner in that area. So if you look at it from a pathophysiological viewpoint, what happens at the time of dissection is invariably the patient will be hypertensive. So there's an increase in the distending pressure. When the dissection happens, because there's two lumens instead of one now, there's an increase in the vessel wall radius. And now, if you look at the false lumen side, there's a decrease in the wall thickness because it's only composed of the adventitia and the media. So it fulfills all three components of the Laplace's law, which in turn increases the wall tension, which causes it to potentially rupture. So that is the main problem with aortic dissection. It's the usual cause of mortality, and the reported incidence of mortality is 1 to 2% per hour. What are the other consequences of aortic dissection other than aortic rupture? So if in a type A aortic dissection, the usual site of the entry tear is just above the aortic valve. So the aortic valve being right next to it, when it aorta dissects, it can affect the functioning of the aortic valve and cause an acute aortic regurgitation. And an acute aortic regurgitation is a hemodynamically significant condition because the heart does not have time to adjust to it and can cause a hemodynamic collapse. A second major consequence of aortic dissection is branch malperfusion. So as we all know, all the organs in the body are essentially supplied by blood branches that come off the aorta. So any branch of the aorta can become malperfused due to this dissection. So it can affect the coronary vessels, the cerebral vessels, the renals, other splanchnic vessels, spinal cord, or even the limbs. What is the mechanism of this malperfusion? If you look at this cross-section image, you have two lumens. So you have a big false lumen, a small true lumen. So this false lumen, under the pressure of the blood, can cause compression of the true lumen, and this compression of the true lumen can cause obstruction to the branch vessel perfusion. So that is the mechanism of how you get branch vessel malperfusion in aortic dissection. And the importance of knowing this is it affects the management also, whether malperfusion is present or not. Taking a step back, how do we classify aortic dissections? So there are two standard classifications, and they're both based on the location of where the entry tear occurs in the aorta, and then also on the extent of the dissection in the aorta. The most commonly used there's two classifications, the DeBakey and the Stanford classification, and the most commonly used and the most easiest to remember is the Stanford classification. It has two types, type A and type B, and basically type A is any dissection which involves the ascending aorta, and type B is a dissection which involves the descending aorta, sparing the ascending. So if the ascending is involved, it's a type A. If the ascending is not involved, it's a type B. And type A dissection is by far the most common and present in 2/3 of patients as compared to a type B dissection. And the importance of this classification is that it's important in that it has differences in outcomes and treatment. So these are a couple of operative images of patients who came to us with aortic dissection. So you can see the hematoma and the discoloration in the wall. This is the ascending aorta, and it's dilated, and the blood running in the wall of the ascending aorta. So what are the common risk factors for development of thoracic aortic dissection? There's a long list of conditions, but things that are the most common that we commonly see is there usually is invariably a history of hypertension, particularly uncontrolled. There are a couple of genetic conditions which commonly predispose. Of these, which we see commonly, are Marfan syndrome and the bicuspid aortic valve. And also another condition which we see occasionally and which you should keep in mind is pregnancy-associated aortic dissection. Other rarer causes, but more commonly seen nowadays, is a dissection associated with drug use, especially cocaine, sudden unaccustomed weightlifting or other valsalva maneuvers, and patients on chronic corticosteroid or other immunosuppressive agents. So what is the clinical presentation? How do these patients present in the ER? So the most common presentation is acute onset severe pain, and which presents either in the chest or the back. And patients usually describe it as the worst pain that I have ever experienced. This is present in up to 80 to 90% of the patients. And the location of the pain is also an indicator of what type of dissection it is. So if it's a type A dissection, remember it involves the ascending aorta. So the patient usually presents with pain in the chest. So in the front of the chest, they present with pain. And as the dissection migrates along the aorta to the descending into the abdominal aorta, the patient even may classically say the pain has gone to the back, initially the upper back and then to the lower back. So that is a diagnostic clue to the location of the dissection. Whereas patients with type B usually present initially itself with just back pain because the site of the initiation of the dissection is in the descending thoracic aorta. Then if the patient presents with malperfusion symptoms, some patients, the pain may not be so significant, so they can present with just symptoms of malperfusion. So this is where it becomes tricky, because this is where they can masquerade as a different disease. And then again, it depends on which territory is malperfused. So if the coronaries get malperfused, we can present with chest pain just like an MI, and if you do an EKG, you will get changes suggestive of an MI. If there's a cerebral malperfusion, he can present with stroke or coma. So he can just present with a coma and no other symptom, and you will never suspect it to be a dissection. If the spinal cord blood vessels get malperfused, he can present with a paraplegia. If it's the visceral vessel, something in the abdomen, he can present with mesenteric ischemia. So he'll present with abdominal distension and pain. And if any of the limbs are malperfused, he can present with acute limb ischemia, or a difference in blood pressure between the limbs, or even a pulse deficit. So those are the symptoms of malperfusion. And then rarely, like I mentioned, they can present with rupture. So if patients are lucky enough to reach the hospital, they'll present with circulatory shock. And so it will be a rare, one of the rare conditions we can present with shock in the ER if they reach the ER alive. Or they can present with acute severe AR. Like I mentioned, if in a type A, if it's close to the aortic valve, it can cause an acute AR, and they can present with dyspnea, orthopnea, or even shock. So again, just to remember the most common clinical profile, so you can't remember all these things. So if you look at the most common profile of a patient presenting in dissection, 2/3 of aortic dissection patients are males. Most common age group affected is more than 70 years. So if you take it by age cohort, more than 32% patients are above 70. But we should also remember that 7% of patients can present below the age of 40. Even in our series, we had 5 patients who presented below 40 years of age. They invariably have a history of hypertension, and the usual presentation is abrupt onset of severe chest or back pain. So the aim of clinical examination is, one, obviously to make the diagnosis, and the second thing is to look for evidence of malperfusion. And why that's important is, like I mentioned earlier, malperfusion is one of the most major determinants of mortality and can also affect the treatment strategy. So what we should look for if we're looking for malperfusion, look for pulse deficits, look for any disparity in the BP in the limbs, look for any abdominal distension, absence of bowel sounds which indicate mesenteric ischemia. We can look for low urine output, again a sign of renal malperfusion. And we look for any focal neural deficits or any decrease in the conscious level, which will again indicate cerebral ischemia. Coming to investigations, so a patient coming to the ER, again with chest pain, what are the most common investigations we would do would be the EKG and chest X-ray, but again, both of these are pretty non-diagnostic. The EKG is usually non-specific unless coronary malperfusion is there, where the changes suggestive of MI will be seen, but then we'll be falsely going down the track of investigating for an acute coronary syndrome when the actual problem is in the aorta. The other examination, the bedside chest X-ray, again will be non-specific. 50% of patients will have some degree of mediastinal widening because of, like I mentioned, once the aorta dissects, it becomes bigger. But then in the ER you'll be doing an AP film, so invariably you'll get a false impression that the mediastinum is widened. So again, very non-specific. Is there any blood tests available? Yes, there is a marker which we can be used, which is the D-dimer, which is mainly used as a rule-out marker because it is non-specific. It's also high in the 2 other deadly diseases which present with chest pain, myocardial infarction and pulmonary embolism. But like I said, it can be used as a ruled-out marker. So if you do a D-dimer and you find level is less than 500 in a patient with chest pain, it virtually rules out aortic dissection as the cause. Are there any scoring systems available? Yes, there is for the clinical diagnosis. It's called the Aortic Dissection Detection Risk Score, the ADRS. It has 3 domains, with each domain assigned 1 point. Any factor present in each domain is given a score of 1, with a maximum of 1 for each domain, for a maximum score of 3. The 3 domains are high-risk conditions, high-risk pain features, and high-risk examination findings. Under the high-risk conditions usually are included a history of any connective tissue disorders like Marfan's, Lewis-Dietz, Ehlers-Danlos, any other family history of aortic dissection, family history of thoracic aortic aneurysm disease, any known aortic valve disease. These are all high-risk predisposing conditions. So any of these presents give a score of 1. Yes, high risk pain features like acute onset chest or back or abdomen pain, which is severe, sudden, and ripping and tearing, you get a score of 1. And if you have high risk examination findings, presence of pulse deficit, a systolic BP difference between the two limbs of more than 20, any presence of a new focal neurological deficit, or the onset of a new aortic regurgitation murmur, gives you a score of 1. So the scoring system is scored from 0 to 3, with 0 classed as low risk, 1 as moderate risk, and 2 to 3 as high risk. And it has a diagnostic sensitivity of 95% and can be combined with D-dimer to increase its sensitivity. But for the definitive diagnosis, imaging is needed. So what are the imaging that is done? There are basically 3 imaging modalities which are in use. One is the echocardiogram, the second is the CT aortogram, and the third is the MR aortogram. The advantages of the echo, as we all know, is it's bedside, it can be done faster, and it's cheaper to do. The CT aortogram is the gold standard currently for the diagnosis. Why? Because it gives you a complete picture right from the root of the aorta all the way down to the femoral arteries. It's relatively quick, but the disadvantage is you need to shift the patient to the CT scan room. The MR aortogram doesn't have much of a role in initial diagnosis, and it's more value comes in follow-up of these patients, in patients with renal dysfunction who have high creatinine, and also it's much more time consuming. So these are just echo images of what an ascending aorta dissection looks like. You can see the characteristic flap in the aorta and 2 lumens. That's how you make a bedside diagnosis. The advantage of the echo is in the unstable patient. When you have a patient coming to the ER with low BP and you suspect aortic dissection, you don't have time to shift him to the CT scan and confirm the diagnosis. So oftentimes we can just rely on the echo and shift him to the aorta and shift him directly to the operating room, and then confirm on table with a transesophageal echo the diagnosis of a type A aortic dissection and proceed to surgery. But I'd still want to emphasize that a CT aortogram is and should be the gold standard in the diagnosis of type A aortic dissection, because not only does it give us a more complete picture, because it shows us exactly where the entry point is and where the entry tear is in the aorta, but also the extent of the dissection, what's happening downstream, because echo will only show you that the presence of a dissection or not. It doesn't say what happens to the branch vessels, whether they're malperfused or not, whether the visceral organs are being filled, being perfused at all. So that idea comes from the CT scan. So if you go into the OT without knowing that, you may land up in trouble. So if you have time and the patient is stable, always get a CT aortogram before proceeding for surgery. Coming to the medical management, one should remember our aim medically is to decrease the chance of rupture. So like I mentioned earlier, it follows Laplace's law, and the only thing that is within our control in Laplace's law that we can do to decrease the chance of the increased wall tension is to decrease the distending pressure, and that is the blood pressure. So the aim is to decrease the aortic wall stress. So one, pain management is very important. These patients come in severe pain, and that pain drives blood pressure also. So pain management is important with morphine. Bringing down the heart rate below 60 is ideal with IV beta blockers, whichever is your choice, metoprolol, labetalol, or esmolol. And then if the BP is still not controlled, you can add arterial or venous dilators like sodium nitroprusside or nitroglycerin infusions. So definitive treatment of a type A aortic dissection is by surgery, and it's an open surgical repair as of now. There are other options which is more done for further downstream repair like type B dissections or management of downstream problems after repair of the initial type A aortic dissection by endovascular repair, which is basically use of endovascular stents or aortic stents to replace parts of the aorta. And there is also hybrid, a combination of open and endovascular repairs. So surgical treatment for type A dissection, basically the aim is to replace the aorta involved with the entry tear. So we cannot obviously replace the entire aorta in one go. So basically, if it's a type A aortic dissection, our aim is to replace the aorta involved with the entry tear. That again entails where exactly the tear is present. So if it's in the aortic root, we'll do an aortic root replacement. If it's in the ascending aorta, we do an ascending aorta replacement. And if the tear is in the distal ascending, we do an ascending and arch replacement. So an aortic root replacement or the Bental is basically a procedure involves excising the aortic root, replacing the aortic valve and the ascending aorta, and a reimplantation of the coronary arteries. Valve sparing aortic root is another option where we preserve the aortic valve and replace the aortic root. And then if the tear is just in the ascending, we can get away with just an ascending aorta replacement. And like I mentioned, if the arch is also involved, we may also have to do an ascending plus arch. What we use to replace the aorta is with something called a Dacron graft, which is the workhorse of all aortic replacements, and it comes in various sizes and shapes based on which part of the aorta replaces them with bifurcated or branched grafts. And this is what a picture looks like of a replaced ascending aorta with a Dacron graft. Thoracic endovascular aortic repair, or TEVAR as it's called, is the keyhole repair of aortic aneurysms and dissections. And like I said, it's primarily used for repair of type B dissections, and basic procedure involves passing the stent through the femoral artery, crossing the area of dissection or aneurysm, and then replacing it with this stent. Follow-up of aortic disease aortic disease is a lifelong disease. Its 10-year survival is only around 30 to 60%, and the main problem is due to the downstream problems in the aorta. So we need to do serial surveillance by periodic CT to know what's happening to the downstream aorta, and meticulous heart rate and BP control is the mainstay of therapy. So this is an example of one of our patients who underwent a type A aortic dissection repair on the 1st of June 2018. He came with an outside CT, so we don't have the pre-op images, but this is his first post-op CT before discharge. We usually do a post-op CT if there's no pre-op CT available. And at that time, you can see this is the descending aorta just at the level of the left atrium level, left pulmonary vein level, and you can see it was 3.86 centimeters. He came to us for his first visit 1 month after discharge, and at that time he was complaining of back pain. So we did a repeat CTC. The time interval is just 20 days apart, and you can see at the same level, the aorta at that level has increased from 3.86 to 4.65. That's a significant increase. So it still hadn't reached the size to operate on, but because of the significant increase, we asked him to come back after a month. And on 31st of July, that's like 1 month later, we did a repeat CT. So this is his third post-op CT over 2 month period. And you can see at this point, it had gone to 5.1 centimeters. So it grew another half a centimeter in just 30 days. So that's a significant growth of the aorta. So we couldn't wait any longer, and then we proceeded to replace his descending thoracic aorta also on the second operation. And you can see this is a follow-up 1 year after that. This is the replaced descending aorta and the replaced ascending aorta. So coming to our dissection data from Amrita, from 2016 we've operated on 48 cases of type A aortic dissection. And from 2018, we've only had like one mortality, which comes to around 4%. If you compare this with the international registry, the normal mortality for aortic dissection is from 17 to 25%. And the Mayo Clinic and the Cleveland Clinic, two premier institutions in the West, their dissection mortalities is around 5 to 10%. So we're doing pretty well. So what happened to Mr. John finally? So this was his CT image just before taking him into the operating room. You can see his descending aorta is normal and just his ascending aorta is dissected. This is the distal ascending aorta while the dissection is ending here. If you look more closely, you can see it actually ends in the brachiocephalic artery. So it's a limited type A aortic dissection. So we went on emergency bypass, replaced his aortic root and ascending aorta, and repaired the re-entry tear in the base of the brachiocephalic artery. He had an uneventful post-operative recovery, and you can see the follow-up CT showing that a normal filled brachiocephalic artery and a normal aorta. And he actually came in the newspaper also because we did 4 of these surgeries in over a 10-day period. So it was quite uncommon to have 4 aortic dissection surgeries over 10 days. So this is Mr. John in the newspaper. So lessons learned from our experience: aortic dissection is a nasty disease with patients capable of dying in front of your eyes. It's a multidisciplinary effort involving cardiac surgeons, anesthetists, intensivists, cardiologists, ER physicians, radiologists, and the nurses. And for that reason, and among other aortic diseases, we've also started a Center for Aortic Diseases and Marfan Syndrome, which is a multidisciplinary effort involving people from multiple departments who combine their expertise to treat these patients. And an example of that aortic team approach is like one patient who presented as a 39-year-old male with a type B aortic dissection with a large DTA aneurysm. You can see here large aneurysm in the proximal descending aorta. So our plan initially, because it was arising just distal to the subclavian arch vessels, we decided to do a hybrid repair, which is a combination of open and endovascular. So in the hybrid repair, it's basically what's done is you debranch the arch vessels. You connect the right carotid to the left carotid to the left subclavian, and then cross the aorta with the stent to cover the aneurysm. So this is a picture of the arch vessel debranching done from carotid to carotid and then carotids to subclavian. Then this is the cine angiogram showing the large DT aneurysm, and this is the final result with the endovascular stent covering the arch and then all the branch vessels being perfused from the brachiocephalic artery. So in conclusion, type A aortic dissection is a rare but deadly disease. It usually presents as the worst chest pain ever in a hypertensive patient. It can have a myriad presentations. Early diagnosis is the key to improve survival. Awareness, early institution of BP control, and a clear defined treatment pathway is essential to improve the survival of these patients. Thank you.
Thank you, Dr. Kiran. That was very, very informative. And I'm sure all of you enjoyed today's sessions. And there was a lot of learning points for each one of you. So that's the end of day 4, and see you tomorrow with the next topic. Thank you.